Hey everybody, Dr. Patel here. Hope you all are doing well this Friday afternoon. Thank you so much for joining me. Today we're going to be talking about PRP injections for the low back. Um, we've been talking about low back a little bit now, and I've had a bunch of previous videos on various different back conditions. And even some videos talking about back anatomy. So if you haven't seen those videos, then I definitely recommend watching those. I think it's going to be important to get a little bit of a sense of the anatomy. Now, we're definitely going to be going over some anatomy today and talking about the different things that could be causing low back pain and how PRP can be used to manage those conditions. But for an in-depth dive into the anatomy, please check out our other videos. You can see them on Facebook, on our YouTube channel, or on our website, fxregencenter.com. And if you have any topics that you want me to discuss, or if you have any questions or concerns, or if you want to talk about your back pain or general questions at all, then please feel free to comment. You can DM, you can email us at info@fxregencenter.com. And if you want to discuss your back pain more in depth, then I'd be more than happy to take care of you. You can always call us or email us. Again, the email is info@fxregencenter.com, and our phone number is 310-929-9790. And finally, if you do like this video, then please like, subscribe, and share to all of the people that you want to know about back pain and PRP treatments for it. So today, we're going to be talking about back pain and treatments for that back pain. And I'm going to play around today. We'll see how this goes. I'm going to play around today with this cool little anatomy model that's by human.biodigital.com. Really cool resource, especially for all you clinicians out there. It looks the anatomy is pretty accurate, and for those that want to play around with it from a patient standpoint, some really interesting things that could be found on there. But I'm going to go through some of the anatomy here. Right now we're looking at the low back, and we're looking at the superficial layers of muscle. These are the big latissimus dorsi muscles that go all the way up to the upper arm. And the reason that I wanted to point this out is because this anatomy ends up being important, as the latissimus dorsi is a strong muscle and stabilizer of the low back, and the fascia, the soft tissue that surrounds that latissimus dorsi, also goes throughout the upper and lower back regions here, and can get involved with pain both directly and structurally. That fascia is continuous with the different fascia that continues on with the buttock and hip musculature. And one source of pain going into the buttock region could actually be coming from these little tiny nerves that you see that are traveling through this area, which are your cluneal nerves. But I'm going to strip away some of the muscular structures here and go a little bit deeper. When you take away some of the more superficial muscles, we're left with these guys here, which are part of the paraspinal muscles. And these are muscles that go across multiple segments of the spine, and they're in charge of stability across multiple segments. You also have other muscles like your transverse abdominal muscles that are one of the deep muscles that go around into your core. And then when we look down into the hip region, you have muscles like your gluteus minimus, and before that you have your gluteus medius, that are really, really important muscles when it comes to the stabilization of your hip. And oftentimes when we have low back pain and conditions going on with your low back, it's this gluteus medius muscle that gets really, really involved. As we strip away some more layers of muscles here, we can see underneath the transverse abdominal muscles have your quadratus lumborum muscles. And these quadratus lumborum muscles are the muscles that connect your hip, your iliac crest, all the way up to your ribs. And these muscles, again, are deep stabilizers of the back. Now, A lot of times, these poor muscles get demonized when it comes to back pain, and people say, hey, my QL is tight, my QL is tight. And sometimes it is, but oftentimes this muscle feels tight because, again, it's reacting to the other stuff that's going on inside the low back. So as we strip away those muscles a little bit further, we get to see some of the deeper stabilizer muscles of the low back, and these are your multifidi. Now, these multifidi get their nerve innervation from 1 or 2, sometimes 3 segments, whereas the paraspinal muscles that go across multiple segments get their innervation from multiple segments there. So what happens is when we have a low back condition that might be aggravating 1 or 2 levels of nerve irritation, these small little multifidi muscles then start to actually atrophy. And not just those small multifidi, but you have these smaller muscles that go across the different areas here. If I can just point these out, these little rotatory muscles that are involved with stabilization in the rotational aspects of the spine. So all of these little guys that get their nerve innervation from 1 or 2 segments then start getting weaker when we have something going on in the low back. And ultimately that decreased strength of those muscles then causes our bigger paraspinal muscles to then tighten up. And this is when we see some of the pain that goes across multiple levels. Like, yeah, I had back pain that started with my low back, but over time it started to stretch all the way up to my upper back, and that's because of those muscles that are firing. Now finally, when we look deeper than the muscles, we start to get to these ligament structures. Now the ligaments are the gray structures. You can see a perfect example of these with the sacroiliac ligaments here. You have this example of a ligament that is on the top of the spinous process, which are these bones right here. The nubbins that we feel on the back of our spine have these ligaments connecting them. Then in between that, we have the inner spinous ligaments, and those connect all the way down to the ligamentum flavum. Now this is all important because these ligaments are supportive structures for each of these segments. Now we have ligament tissue surrounding the facet joints and capsules. We have ligament structures that are connecting the transverse segments of the vertebral bodies. And then we have ligaments that are connecting the low back to the iliac crest. If you've heard me talk before, you've heard me say that the ligaments are like the duct tape that connects bone to bone, but rather than duct tape, they're like those thick rubber bands that surround broccoli in the grocery store. Those are strong supportive structures, but they also have some stretch to them. And that's why when we have some disc degeneration, we start to get some mobility in those regions. We start to get some looseness of those ligaments, and over time, those rubber bands start to get a little looser. Now, as that occurs, look at that. Those are all your organs there, right? As those rubber bands get looser, there's some more movement that takes place and more instability that takes place that can then cause aggravation to various structures. So beyond the ligaments, right, if we zoom in a little bit here and actually remove some of these guys, hide this one. If you look past these ligaments here, you can see all of these nerves. These are the nerve roots that are traveling in the central canal of the spine. And these nerve roots then exit out of the spine on either side as the spinal nerve roots. And these nerve roots then go down the legs in different distributions. Now, when we think about back pain, there are a lot of different things that can cause back pain. There are things like the facet joints, there are the ligaments, there are the muscles, there are the discs, and finally there are the nerves. Nerve irritation typically causes pain to go down the legs, but can certainly contribute to pain in the low back. The facet joints, or the capsules that surround them, can certainly cause pain. The ligaments, if irritated, can cause pain. And then deep inside here, you can picture the discs can cause pain as well if they are injured. Now, typically with pain management, the strategy is, let's figure out what the pain generator is, and then inject that with cortisone to calm down the inflammation and then decrease the pain. But really that decreases the inflammation and pain, but really doesn't do anything about the structures or the elements that were causing pain in the first place. So we really don't do anything for the discs, the joints, the ligaments, the muscles, any of those guys. And ultimately, we're left with a temporary Band-Aid that reduces the pain for X amount of time. Typically, it's anywhere between weeks and a couple months. And the good thing about that is if we strategize around a corticosteroid injection appropriately, we can use the time period that we have when the steroid provides relief in order to then get the body moving correctly. Physical therapy, exercise, etc. And that's the stuff that ultimately can provide us long-term relief. But PRP, or platelet-rich plasma, has more of an effect than just pain management. Now, there's a big difference between PRP and corticosteroid. By and large, if you just look at the research comparing steroid injections to PRP for various different areas, knee joints, ankles, foot, shoulder, whatever, right? Short-term, cortisone has a better pain relief, and then medium to long-term, PRP has better pain relief. And that's because PRP causes inflammation and then takes inflammation away and actually induces the body's own innate ability to heal. So that being said, it can help with pain generators, but PRP can also help with structural elements that may be involved. I mentioned before that when we have some degeneration of things like the discs, those are the water balloons that are in between the vertebral bodies, and if those get a little bit more wobbly because there's less water in them, we can start causing more pressure onto the facet joints. We can cause more stretch to the ligaments. So even if we're not necessarily getting pain from the disc or pain from the ligaments, these structures are still involved as a part of the picture. Even though the muscles that may be tightening up in reaction to what's going on may not be the primary pain generator, they're still probably contributing to some of the pain. And more importantly, if those muscles are weak, then it can be contributing to some instability and then just causing pain at whatever the main pain generator is in the first place. But what if we had a tool to help strengthen those muscles, strengthen those ligaments, strengthen the disc material, and calm down the nerve irritation, and calm down the inflammation of the facet joints, right? That's the true benefit of PRP, and the true strategy that should be used for low back pain conditions is therefore not just treating the pain generator, but addressing the whole functional spinal unit. So the concept of a functional spinal unit is actually an old concept that was created by some surgeons named Punjabi and White that were looking at the anatomy of the spine and published a textbook many years ago. This is from one of the presentations that I give to various people. The concept is that even though there might be one thing that is a pain generator, all of these elements are really interrelated. And in this you can see the ligaments that connect bone to bone in front of, behind the vertebral bodies. You have the ligaments that are surrounding the spinal canal. You have your intervertebral discs, your bones, your facet joints, your ligaments in between the spinous processes, it's covering the spinous processes. What's not in this model are the things like the fascia that surrounds the region, the nerves that are going to these regions, right? All of these things are a part of the functional spinal unit. And if we accept the fact that our orthobiologic procedures such as PRP may be able to provide some strengthening to the various soft tissue structures that are involved with the functional spinal unit, we recognize that we can get structural benefit to the area and get improvement of the symptoms more long term. One of my colleagues, this is data from Dr. Chris Williams out in Atlanta, and this is unpublished data, but it shows basically that treating just the facet joints with PRP, just the pain generators with PRP, versus treating the facet joints, the ligaments, the epidural space, etc. Treating the facet joints did provide benefit, but then that benefit started tapering off as time proceeded, versus the benefit from treating all components of the functional spinal unit actually continued to improve. So that being said, the real approach to using PRP in the spine should not be as simple as just treating the pain generator. PRP is not the same thing as a steroid injection. It's not just what's the magic juice that we're injecting to the thing that's causing pain. We really need to take a step back and look at the whole picture and recognize all the different things that are involved. And we have some information to support that. We have a lot of internal data that shows that we can get benefit for extended periods of time. And we do have one publication that looked at a case series for lumbar spine, one report for the cervical spine, and interestingly, we have a prospective controlled trial looking at patients with severe degeneration of their spines that were treated with bone marrow aspirate, not just PRP, but bone marrow aspirate, kind of, again, addressing all the different components of the functional unit and getting benefit. Now, the research is still very, very small in this field, and you can imagine it's challenging because, the ideal research is like, all right, let's hit this one target with either A or B and see which one works, right? But when we have a situation like this, when we have multiple different targets that are involved, it ends up being challenging to do some really high quality research for this type of scenario. That being said, we do have data that does support benefit for these type of scenarios. And we have data that lasts for an extended period of time. There's definitely information out there, and this is some of my data. It's a little bit old now, but it shows looking at many of our patients with low back conditions, we were able to see that were treated with blood platelets. We see over 50%, at or over 50% improvement that's sustained even up to the 5-year mark and beyond. So all in all, this approach at treating the whole functional spinal unit is the way that we should be using PRP for low back pain conditions. Really, that's the approach that we should be using for any condition that's more than just mild. Like a mild knee arthritis can probably benefit from just injecting PRP inside the joint. But once we get into the moderate stages, we need to really look at the whole picture functionally, addressing not only inside the joint, but outside of the joint, and sometimes even inside the bone. And that same model needs to be used for low back pain, neck pain, and really anywhere in our body. So I hope that all made sense. Obviously, we went over a bunch of stuff there. And like I said, I was talking at a little bit of a higher level when it comes to the anatomy and different pain generators. If you are interested in learning more about the anatomy, I have some great talks on the anatomy of the low back. So please check out our website, fxregencenter.com. You could find all our old videos on our YouTube page and on our Facebook page as well. And check out the videos on the anatomy. A lot of what I discussed today, rewatch it after you've watched the anatomy lectures because it'll make a lot of sense. But I think that the message is clear that we can get benefit to patients with low back pain conditions, but it really is a matter of hitting things systematically and in a comprehensive fashion. If you like this video, please like, subscribe, share, all that fun stuff. If you have questions, comments, please send them our way. Thank you so much, Leanne and Debbie, for joining us. And for all those that didn't comment, thank you too. And wishing you guys the best for the rest of your Friday and this weekend to come. And I will see you all next time.